Hello, everyone. I'm Dr. Jerry Lowder. I am here today as the Vice Chair of the Publications Committee. I'm also Professor of Urogynecology at the Washington University in St. Louis School of Medicine. And I'm here today with Dr. Evelyn Hall, who's Assistant Professor at Tufts Medical Center, and she's also the first author of the paper entitled Medium-Term Outcomes of Conservative and Surgical Treatments for Stress Urinary Incontinence, a Medicare claims analysis developed by the American Urogynecologic Society Payment Reform Committee that's going to be published in Urogynecology. And today we're here to discuss the paper. And so, Dr. Hall, I'd like to start off and ask you to tell us a little bit about this paper and specifically what were the objectives.
Thank you so much, Dr. Lowder, for the introduction, and I'm excited to share the findings of our paper. So the goal for the paper was to look at medium to long-term outcomes of women in a Medicare data set, so 66 and older, who were seeking care for urinary incontinence. And we looked at women and followed them through their basically urinary incontinence treatment pathway. We looked at patients who were receiving pessary, physical therapy, or sling surgery, followed them between 3 to 5 years to see if they got an additional type of treatment for their stress incontinence. And so, for example, if they had a sling surgery and then they went on to receive bulking, or if they had pessary and went on to get a sling surgery.
So, Dr. Hall, what did you find?
So we looked at women between 2008 and 2013, and about 13,000 women were included. So in this cohort, 41% received pessary treatment, 32% received physical therapy, and 27% underwent sling surgery. So some interesting things. First off, women who underwent sling surgery were younger than women who received physical therapy or pessary. There was also some regional differences in the cohort. So women in the Northeast had a greater probability of receiving pessary compared to other regions. And women in the South had a greater probability of receiving sling surgery. And we followed women again for that 3 to 5 year period. And we looked at retreatment as a proxy for failure. And what we found is that women who received pessary had the lowest retreatment rate. Their survival probability was 0.94 compared to a survival probability of 0.90 for physical therapy and 0.88 for sling. And another thing that we noted was that a significant proportion of women who received treatment with physical therapy or pessary ended up requiring repeat physical therapy courses or additional pessary fittings. And so we basically did a secondary analysis that said, well, if we count a repeat pessary fitting or repeat PT course as a failure, what do we see? And then we saw some differences. So in that secondary analysis, we saw that sling was the most durable or had the lowest retreatment rate, followed by physical therapy and pessary.
So, Dr. Hall, how did you decide what the important points were?
So we were interested in real-world data utilizing a Medicare claims data set. And what we found was a small but statistically significant difference in treatment failure between sling, physical therapy, and pessary treatment, with pessary treatment patients least likely to cross over to another treatment. But we felt, again, it was important to look at the need for repeat courses of physical therapy or repeat pessary fittings. So we did a secondary analysis where we considered someone who was fitted with a pessary and then got a second pessary to be a failure, or if they had physical therapy and then several months later, 6 months later or greater, needed another course, that was also counted as a failure. And what we found in the secondary analysis, that women in the sling group were the least likely to have treatment failure, and women undergoing initial pessary treatment were the most likely to have failure. And so based on this, we would recommend women who are interested in conservative treatment for urinary incontinence to anticipate the need for repeat pessary fittings or repeat physical therapy.
Excellent. And then any points of controversy that you found in this work?
So we used retreatment as a proxy for failure. However, we know that in any large retrospective cohort study that there are going to be limitations. We don't have patient-reported outcomes. We don't know about patient satisfaction or success. Some patients might have had treatment failure, but might not have elected or been offered retreatment. And so our ability to generate conclusions is limited. Additionally, we used CPT codes, and for example, the sling code includes both a mesh midurethral sling as well as a pubovaginal sling, and we know that there are treatment efficacy differences as well as complication risk. Our data was collected from 2013 or 2008 to 2013, and there were really low rates of urethral bulking. So we couldn't look at the overall treatment failure rate of urethral bulking. And so it's can't really comment on how that would look in this real world population and would likely look different today. And finally, our data predominantly represented white women, and women of color were underrepresented in this cohort. And this could represent a disparity in lack of access to care, lack of self-reporting, or bias from clinicians addressing this medical condition.
And then finally, what are future directions for this research?
So I think this is really exciting. This was a study that was a part of the AUGS Payment Reform Committee, which was given a charge to basically develop an alternative payment model for stress urinary incontinence. And Dr. Biller gave a really great interview, which I would definitely encourage you to check out, that highlights a framework for developing this alternative payment model. So this data is really exciting because it shows real-world patients using these different treatment modalities, and we can track women over time and see how they navigate care, as well as we have data on the relative costs of their care, including preoperative costs, surgical cost, postoperative costs, retreatment with different modalities. So that's really what's coming down the pipe for the AUGS Payment Reform Committee, and there'll be additional manuscripts and papers, so keep an eye out for that. We're really excited.
Thank you for coming on and being willing to present about your paper that was published in the June issue of Urogynecology. I think it's going to be of much interest to the readership and members of our field. So again, thank you very much.
Thank you so much for having me.